our cardiovascular program is very comprehensive. We can provide a very wide variety of services locally here in our community, which include state-of-the-art vascular surgery, state-of-the-art cardiology services, including electrophysiology, general cardiology, interventional cardiology with one of the premier Cath Labs in the region. Very busy, very experienced interventionalist, and of course cardiac surgery.
I think one of the nice things about our program is the fact that we do have all those specialty and subspecialty services, so that when patients come, especially in cardiovascular, where they tend to have multiple issues and multiple overlaps of different issues, that they're able to see physicians within the same hospital system, which helps us in communicating with each other and optimizing their care.
So I do mostly general cardiology, which is taking care of the bread and butter of chest pains, heart failure patients, and providing necessary referrals to anybody with arrhythmias or if needing any other cardiac surgery. So this is mostly just the general cardiology, medical part of the cardiology team.
And I do cardiac electrophysiology, which specializes in treating arrhythmias. For people with slow heart rates, we do pacemaker placement, and then there are a variety of different treatments for fast heart rates, ablation procedures, defibrillator implantation, and different medications that we use to treat those rhythms and symptoms.
And I'm a vascular surgeon. I specialize in disease processes that affect arteries and veins outside of the brain and the heart. Some of the more frequently treated diseases include carotid narrowing in the legs, and aneurysmal disease that affects different arteries throughout the body.
So I'm the babysitter that babysits all these doctors, right? I'm the cardiothoracic surgeon, and I treat diseases of the chest. Includes both diseases of the vascular system, the heart, and the blood vessels in the chest. So I kind of complement what Dr. Tretta does with the vasculature in the periphery and the rest of the body. So kind of we work together at times. But I also work specifically on the heart vessels on the heart. On the blood vessels on the heart. And I also take care of problems with the lungs.
And I'm an interventional cardiologist, so that's a Cath Lab specialist basically, and do diagnostic cath and then intervention, which is fixing blood vessels non-invasively in the Cath Lab with balloons and stents. And I also am one of the main sources of patients for Dr. Mavridis and sometimes for Dr. Tretter for patients that have surgical needs that we can't take care of. So and some general cardiology as well.
The TAVR program is something we started about a year and a half, almost 2 years ago now. It was in the works for well over 4 years, getting ready and preparing to be able to provide that service to the community once it was opened up to all medical centers beyond the ones that were doing the initial research. So we were positioned very early. We knew we wanted to provide this type of procedure to the community. We were state-of-the-art comprehensive cardiovascular center, which includes all types of vascular surgery, cardiology, and cardiac surgery. So of course, naturally, we wanted to be part of this and be able to provide state-of-the-art care in the community. So very early on, we started the process, and we were actually one of the first centers between Pittsburgh and Harrisburg, or even further, to bring this procedure to the community. We've been doing it for, we've reached over 60 cases, great success. And the importance about the TAVR is that you bring a procedure to a specific group of patients, and those patients are the very high-risk patients that without this procedure may not be able to have their stenotic valve, the diseased valve, replaced. And the reason is because they're very high risk and they may not be candidates for surgery. As a matter of fact, the TAVR was initially developed for specifically those patients, the ones that have no other option. They cannot be treated with surgery, and the alternative is to get to be treated with medications and eventually continue to deteriorate. So it's a great advancement in the armamentarium of cardiac surgery. It's done in conjunction with interventional cardiologists. So it's a team approach again. You have a cardiac surgeon, interventional cardiologist. You have the team from the Cath Lab, the operating room, the perfusionist, X-ray people. So it's a very comprehensive team approach. We all work together to provide this state-of-the-art service. So valve replacement is part of the cardiothoracic surgery treatment options that we have. We've been doing valve replacements since 1990. That's not something new. It's been going on for a very long time. We've had excellent success. I think what's key, what we're trying to develop is a state-of-the-art valve repair program. And traditionally, a valve repair is a little bit more complicated, more complex procedure. They're not as common. They're not a big number of procedures. So we teamed up with a world-renowned cardiothoracic surgeon, Dr. Pellegrini, who's joined the team. And our goal is to develop a comprehensive valve replacement program, which ties in with our TAVR program, which ties in with our structural heart program, to include other procedures of the heart that are done minimally invasive. So I think this is a great opportunity to have the collaboration for someone of the caliber of Dr. Pellegrini, who's done a vast number of mitral valve repairs, in addition with the local talent and surgeons that we have here in the community.
Well, the Cath Lab actually started here in 1990, so we're actually going on 28 years now, and the first 3 years of that were the balloon angioplasty era. The first stents became FDA approved in 1993. Those were bare metal stents. They didn't have a coating, and they were a big advancement, but you still had a pretty high rate of re-narrowing taking place in the stent site. And then 10 years later, 2003, the first drug-coated stents became approved, and that was another gigantic technological advance, mainly just to dramatically reduce the chance of the blockage recurring at the stent site. So, and then in the last 14 or 15 years since the first medicated stents came out, there just have been a whole variety of advances in the technology of the stents themselves. They just get better and better. I mean, easier to deliver to where they need to go, and really very low likelihood of recurring now. But for us, it's mostly really balloons and stents. I mean, that's the foundation of what we do. And so I would say at this point, it's probably just a matter of just trying to just take small steps now just to get better and better at what we do. The most important situation to intervene in the Cath Lab are the people that come in acutely ill, particularly the acute heart attack patients. I mean, that's probably honestly the most important function that the Cath Lab provides to the community, is that frontline emergency treatment for people that have heart attacks. So that's where you make the biggest difference, because with a heart attack, the quicker you get the blood vessel open, the more heart muscle you save. For people that have stable heart disease, meaning they're not having a heart attack or some like unstable event, it's much trickier, honestly, to try to determine how much of a benefit they get from a Cath Lab procedure. So I think patients sometimes in general tend to undervalue the role of medical therapy. I mean, medicines now are really good. I mean, you can get people basically do equally well on good medical therapy as when they get stents and so forth in most situations. And so what we do in the Cath Lab, it's not like an either or type thing. It's not, you put in a stent or you take medicines. I mean, it should be, the foundation should be good medical treatment, good comprehensive medical treatment. And then if people are still having symptoms or still having problems despite good medical treatment, then somebody like me can perhaps find something to put a stent in, and that may, make a difference to help their symptoms.
So electrophysiology or cardiac electrophysiology is a subspecialty of cardiology where we're specifically treating arrhythmias that people have. So an arrhythmia meaning that an irregular heartbeat. It can be a slowing down and speeding up of the heart rate. You can have heart rates that suddenly go very fast and require medication or other intervention to slow the heart down. Or people can have slow heart rates and they can develop for a variety of reasons. May be some underlying disease like coronary disease or high blood pressure, or as people age, we're all can be susceptible to what we call conduction disease or slowing of the heart rate. Some of the original treatments that we have that we still very widely use are putting in pacemakers to treat slow heart rates. There are defibrillators, which are primarily they're used to treat fast heart rates. People who are most at risk for these fast heart rates, like ventricular tachycardia or ventricular fibrillation, that can cause cardiac arrest and sudden cardiac death. Those are commonly people who have history of heart attack or weak heart muscle or other genetic or family-related diseases that can make them susceptible. The defibrillators have become much more complex, so they have what we call resynchronizing devices that can actually help people help their heart muscle get stronger and help to treat their symptoms and prevent their heart failure from worsening over time. And then on the other side, we have ablation procedures, which are all typically aimed at treating fast heart rates, whether they're in the top chambers of the heart, like atrial fibrillation, which is a very common arrhythmia that people develop, or ventricular arrhythmias in the bottom chamber. We can use different techniques of mapping out these circuits in the heart, these extra circuits, and then we apply either heat or freezing techniques to break those circuits or stop those trigger points and help prevent those arrhythmias from happening. And I think that's where we're seeing a lot of growth as far as being able to treat arrhythmias. Atrial fibrillation is a really big area because it's becoming so much more prevalent across a lot of age groups, even patients in their 20s and 30s developing atrial fibrillation. And we have a lot of technology available for that. And when we talk about going to a center where there's more comprehensive care, we have techniques where you use heating to treat AFib. We use freezing techniques to treat AFib, and even hybrid procedures where we combine electrophysiology-based procedures that I perform along with surgeries performed by the cardiothoracic surgeon, minimally invasive or even open, that would help to eliminate or treat those arrhythmias.
My part is the vascular part of it, and it's very important that the other members of the team keep the heart pumping, because it's able to pump the blood through the arteries that take blood to all parts of the body, including the brain, the kidneys, the intestinal tract, the legs, and then the veins take the blood back to the heart so that it can be reoxygenated and sent out again for nutrition, the nutritional aspects of all of our organs. My role is maintaining those blood vessels, the arteries and the veins. The disease process that affects them is atherosclerosis, causes plaque formation and narrowing, where the blood is not able to reach the organ that it's directed to. And there are processes or procedures that are necessary to open up those areas of narrowing, or fix the veins that are taking blood back to the heart so that the blood doesn't stagnate somewhere in the lower leg. It's really variable because we're dealing with the entire body organ system. And if it affects the brain, they might have a stroke. If it affects the kidneys, they may have renal failure. If it affects the legs, they may have pain in their legs when they walk. And when it affects the veins, it could be something as simple as varicose veins or spider veins, to a more difficult problem of chronic venous insufficiency, where there's actual stagnation of blood and skin changes in the lower legs that can develop ulcerations. So it's very variable depending on what organ system we're talking about and the vessels that are involved. Leg health is important, and it's often discussed about how patients develop DVTs or PE embolisms from taking long trips or sitting for long periods of times. And leg health is important, and it just getting up and moving around and exercising is just part of the heart healthy and leg healthy lifestyles.
The fact that Dr. Treader and his expertise is here would not function, would not be able to do what he needs to do to take care of the patient without the presence of Dr. Shodogam and her expertise, Dr. Stenberg and his expertise, Dr. Everett and her expertise. So we all kind of work together because the patients need all of us. And a lot of times, all of us work at the same time for a particular patient.
The patients that we treat and take care of are complex, and they have complex medical problems, and it requires a team approach. And that's the best way that we can assure that our patients are being taken care of, is when we have multiple specialties addressing the complex issues that arise with cardiovascular disease.
I think it's important too, the fact that we have a comprehensive program and we're able to take care of patients, not just the state-of-the-art interventions that we're doing when people come in severely ill or with very emergent problems, but that people are taken care of, they're on the right medication, and they're being treated in a preventative way as well, because a huge part of this is making sure that all these disease processes are potentially even being prevented from getting to that really severe point where people are extremely ill critically.
In general cardiology world, we deal with doing echocardiograms and doing stress tests. So we have excellent equipment doing the echocardiogram. We have the state-of-the-art, new equipment doing most of the innovative things of doing 3D imaging of the heart, finding out how their function is, looking at the valves. This is basically, this is just the diagnostic part, and this leads on to more complex procedures, which are more interventional. But even the stress test, the nuclear cameras, looking at the perfusion of the heart. We also do CT scans of the heart, which is a non-invasive way of looking at the blood vessels. So we do have a very good equipment here.
From like the electrophysiology standpoint, we have a full array of different devices for implantable monitors, pacemakers, defibrillators to treat a variety of different heart failure related issues. And then we have ablation equipment where we can use different tools to map out arrhythmia circuits in the heart and treat different arrhythmias on the full complexity of different conditions we see.
Yeah, we have a whole array of tools, from identifying patients with or diagnosing patients with the disease process all the way to treating patients. And we use X-ray, we use laser, we use atherectomy devices, and we've been given the opportunity to use a host of tools at our disposal to treat this disease. A lot of the things that we do are done under X-ray with imaging, and instead of turning the lights down, we use green lighting so that we can identify the images at the same time the people in the room are not in a darkened room. So it's just a matter of safety.
For the Cath Lab, the mainstay for fixing blood vessels are balloons and stents. The current stents are drug-coated. They have a medication that coats the surface of the stent, which just reduces dramatically the chance that it would re-narrow again. And we also occasionally use lasers, not very often, but in certain situations in atherectomy, that's the roto-rooter idea, to go in and grind it out basically before placing stents. And maybe the most recent development, this is more a vascular access development, not so much a way to fix blood vessels, but the whole shift nationwide and even across the world has been toward radial access. That's going through the wrist to do your cardiac catheterization procedures, and there's a whole variety of advantages, mainly less bleeding chance, and so that's something that pretty much all of us that work in the Cath Lab here have shifted our practice quite dramatically in that direction. Those are the main technological things in the Cath Lab.
I think there's all this technology that we're talking about here as a group is to try, prevent the disease process or proactively treat patients before they get sick or sicker. But from the cardiac thoracic standpoint, I can say that the program here has been present since 1991 consistently with tremendous results, good quality care, and constantly advancing with the new technology. Very excited that we're in the forefront right now. You don't have to leave town to get the state-of-the-art treatment in cardiac surgery. We perform all adult cardiac operations, including bypass surgery, valve surgery with aortic valve replacement, minimally invasive valve surgery, mitral valve surgery. We have all this technology and capability very close to home, and most people don't realize the state-of-the-art and quality care that all these physicians provide here in the community. Also, I have to say the addition of robotics. Conemaugh has been providing robotic surgery for over 5-6 years now. A lot of physicians are approaching close to 1,000 cases of robotic surgery locally. And I can say that we've adopted that in thoracic surgery. So all of our thoracic cases, lung surgery cases now are done robotically or minimally invasive. So again, that's another service that is provided right here locally, and I'm very proud to be a member of the team that is able to bring this technology here to the community.
Heart failure accreditation is given by the accreditation committee of the ACC. It's a very rigorous process of making sure that the hospital is providing the excellent care for the heart failure patients, which is evidence-based, a very systematic approach. So we went through months of making sure that we were able to do this for our patients, not just while they're in the hospital, even before reaching the hospital, triaging them the right way, and also making sure, on discharge, they have all the things set up the right way and follow-ups. So with that, they gave us the accreditation, making sure that we're delivering evidence-based, guideline-directed medical therapy to our heart failure patient, which basically reduces their length of stay, helps identify really high-risk patients, and timely referrals for advanced medical therapies or even advanced mechanical circulatory assist devices. So this is really a great, place for heart failure patients. They don't have to travel elsewhere to get this kind of care, and I think it's a very well-versed team approach here. Most commonly, chest pains. While doing anything physical, if you notice that you're getting chest pains, or if you're out of breath, normally if you were able to walk a block and now you're not able to because you're out of breath, that's a red flag. You have to talk to your physician, see if you need further testing to make sure that this is not related to the heart. Palpitations are another common symptom from the heart, which could lead, which are probably coming from some underlying arrhythmias. Genetics definitely play a huge role because there are certain genetic disorders that are, from the heart standpoint, which are certain cardiomyopathies, certain arrhythmias that are hereditary. But also cholesterol is a genetic issue as well. So high cholesterol runs in families, and we know with a lot of research over several years that it's basically a major factor leading to plaque built up in the arteries in the heart, heart as well as elsewhere in the blood vessels. If you have a family history of anybody with heart problems, strokes, this is an important risk factor for you. You have to make sure you are checked and check for heart disease in yourself as well. Women basically don't usually have the similar symptoms like men, although they are equally at risk of developing heart issues. Probably they may be a little older when they develop heart issues, but nowadays, now in the last few years, cardiac death is death from heart attack is the primary leading cause of death in women as well. It used to be breast cancer before, not anymore. It is heart issues now. Men may have elephant sitting on the chest, that kind of a picture when they have a heart attack. Women, not everybody feels the same. They complain of real fatigue throughout the day, profuse sweating, bad indigestion, or just not able to do stuff that they usually do. These are common symptoms, abdominal pain, very atypical symptoms that they present with. Definitely need medical attention. Again, for the women, I definitely would say know your risk factors, get yourself a physician, get checked, don't ignore your symptoms, and start leading a healthy life early on.
It's really important to understand that there are some vascular diseases that are silent. And if you have a family history of aneurysms or aneurysmal disease, it's really important to communicate that with your healthcare provider so that appropriate diagnostic studies can be performed to identify a problem. And I think it's also really important for patients to know the symptoms surrounding stroke. And if a stroke occurs, just like when an acute heart attack occurs, it's really important to seek medical attention quickly so that we can initiate treatment quickly and salvage as much of the damaged or threatened organ as quickly as possible. Exercise.
Yeah. That's,
exercise.
Yeah, that's so true. Yeah.
Diet.
100% true.
And when certain disease processes like hypertension and diabetes are present, just making sure that they're carefully controlled and taken care of.
I would stress, and what I tell the patients is, don't wait for your physician to take charge. You need to take charge of your health. You need to be proactive. Okay, if you wait for your doctor to, come down and tell you, you have to take action. No, you got to be proactive. Take care of yourself. And like Dr. Tretter is saying, all of us will tell you, exercise, healthy eating, smoking. I mean, I can't believe that people still smoke to this day. How detrimental is that for the cardiovascular system of the body, for cancer? So, easy to say, sometimes hard to do, but you got to take your care in your hands. You got to be, your own number one advocate of healthier living.
And understanding too that the early stages of heart disease, like high blood pressure and having diabetes, are not necessarily symptomatic. So when you're diagnosed with those diseases, that you comply with the recommendations that your doctors give, and that's the most effective way to prevent the development of the more severe symptoms, where people get angina or chest pain when they're walking because they've already developed a significant amount of cholesterol in their heart arteries, or the same with walking with if they have vascular disease in their legs. It takes decades to develop enough disease where you actually can't walk without pain. So those early treatments of high cholesterol, high blood pressure, high blood sugar are really important.
Take advantage of the services that are provided in the community. Do preventative healthcare checks. Visit your doctor. Ask about lung cancer screening opportunities if you're a long-time smoker that is available to you. Take action in taking care of yourself.
I think that's good. Knowing know your blood pressure, know your blood sugar, know your history and your risk factors, your family history, so that you can be proactive about taking care of yourself.
It's not something you want to put in the drinking water, because really, I mean, it's that's the idea of primary prevention. That's giving a medicine to somebody who doesn't have the disease yet, and because even though aspirin sounds very benign, if you give it to all kinds of people that don't really need it, you're going to create a certain number of GI bleeds. You may even have an occasional intracerebral hemorrhage, bleeding in the brain. I mean, there's bad things that can happen to people that take even a low dose aspirin that don't really need it. So it really needs to be targeted at people that actually need it, particularly people that have established heart disease already. That's clear cut, but people that have multiple risk factors for coronary disease that perhaps don't have the diagnosis yet, smoking, hypertension, diabetes, high cholesterol, family history, those are the key risk factors. So the more of those factors that are in your background, the more advisable, the more beneficial it may be to take an aspirin. The other thing is you don't need more than just 81 milligrams, baby aspirin. More is not, better in case of aspirin. You just have a higher chance of bleeding, but no more effectiveness with larger doses of aspirin. So just 81 milligrams a day if you're gonna take it.
They've had a big change too on the arrhythmia standpoint as far as atrial fibrillation and treating with aspirin. And for people who are low risk, who have atrial fibrillation, who are low risk for getting a stroke from that arrhythmia, aspirin provides very little additional benefit to them. And people who are high risk, we recommend blood thinners like Coumadin or some of the newer oral anticoagulant medications. But again, even in those high risk people, aspirin provides very little benefit. So there has been a real big shift in those guidelines and recommendations from rhythm and from cardiovascular standpoint over the last 5 years.
Patients have a choice, and we know that they have a choice to have their health care locally or wherever they choose. We have the talent necessary, we have the technology necessary so that they can not have to travel and not be inconvenienced by driving miles to receive health care that they can have in their own community.
Also with follow-up care, building a relationship with the physician is very important. If a patient has to travel 60 miles to get that regular care, they're definitely going to drop off. Maybe put off that visit till next time, and that next time never comes. But having that care very, available just within a few miles of their home is very important.
I think our responsibility is to educate the patients. And, we strive to provide the best care possible. And if there is a type of procedure or a treatment that is not available locally, by all means, we are the first ones who are going to send that patient out to get the proper care that they need. The key is that the care that we provide here that's available, it's the best care possible. But you also have the physicians that are within the area, within your community, taking care of you. So you are cared as a person, as a whole, not just as a number that goes to a big institution that they'll get you in and out and treat you just for your disease. I mean, we treat the whole patient here. So in my mind is we can provide not just as good care, better care than what you're going to receive somewhere else. Then I have to educate the patient and explain that to them so they can understand it and feel comfortable with that. And then I know they'll stay here and get their care here.
I've chosen to practice here because it's where I've chosen to call home. And so it's important that, to me, that I'm involved with providing health care to the community that I call home.
I chose to come here and have been here for 6 years now because of the fact that when I came to visit and came to interview, I was so impressed with the size of the hospital, the medical staff, and how comprehensive our cardiovascular program was. And at that time it was lacking in my specific specialty, and but all the other pieces and all the support that we needed to build the program was here and very strong. And so it's been great.
I chose to be here because it's a team approach everywhere. It's not just an an individual. I never felt alone as a physician. I have always, the whole team is here to support each other. And again, I felt like I was doing everything that I was trained to do, not just sit in the lab or just be on the floor. So everything that I was trained to do, which you probably will not be able to do in bigger institutes, you're kind of you have to pick a specialty and just sit there doing that. But I love doing everything that I'm doing here. So.
Yeah, and I came here, I'm originally from Seattle, so not from this area, and trained elsewhere. Ended up coming here in 1990 when the Cath Lab and open heart surgery program were starting. So that was what got me here, actually, was to start the Cath Lab program. But what has kept me here is that it became a really busy and successful program, and although I had never lived in Pennsylvania before, it turned out to be a great community to live in, a great place to raise children. I mean, it's home for me now. So I really just like everything about Johnstown, and I think Conemaugh has been a great hospital to be a part of for all these years.
A similar story. I've been here for over 20 years now, and I did my training here initially. That's what brought me to the area, and realized that this is a phenomenal, state-of-the-art hospital that most people don't realize. So I went away and did more training in cardiothoracic surgery, and of course it was a natural decision. My wife was from the area. We came right back, and we love the community. It's a great place to raise a family, and to a lot of people it's very surprising that it's a tremendous healthcare system. It's a huge program in a small community, so it's a great place to live and a great place to practice.